I'm going to share my screen.
Okay.
So thank you everyone for joining. This is the HeartBrothers monthly patient support group. I'm Hamid Madavi. I'm a heart transplant survivor. So thank you for joining us. So for those of you who don't know us, we're Team HeartBrothers. We're patients just like you, traveling the heart failure journey. After our transplants, we've decided to give back to the heart failure community. Our mission is to help and support heart failure patients and their loved ones navigate a life with heart failure and all its challenges. I want to thank our sponsors today, who without them doesn't make this program would not be possible. Transmedics Corporation, Medtronics, Cytokinetics, Abbott, CareDx, and Novartis. So just a quick rundown of the events that we have. We have a monthly patient support group meeting the second Thursday at 6 p.m. every month. We have 8 webinars focused on various aspects of heart failure. So the next webinar coming up will be on Hypertrophy Cardiomyopathy, April 21st at 5:30 p.m. August 1st, we'll have our 6th annual Gustin Golf Classic. September 23rd, we'll have Friendly Feud 2. It's a fundraising night. It's a big event in Newton, at the Marriott Newton. Then October 2nd through 10th, we'll do our annual member for a day golf auction. And then December 1st and 2nd, we have our annual Team HeartBrothers Symposium. So I just want to make a note that what we share here in the patient support group is that it's based on each of our own personal experiences using our individual judgment and knowledge. Please consult your physician and treatment center regarding what approach and strategy is best for your specific conditions. Obviously have a very qualified and capable physician tonight with us, Dr. Richard Siegel, but nevertheless, please consult your center before making any medical decisions or changes in your routine or prescription.
Manufacturing bill, his team said would bring down inflation. Biden talked about just about everything: climate, clean energy, historically Black.
So available resources, we have the HeartBrothers House. It is basically a 2 luxury apartments in downtown Boston, available to heart failure and transplant patients being treated in the greater Boston hospitals. It's available on a first come, first served basis. It is $45 a night, including parking, which is a pretty phenomenal deal. You can get information on it by going to our website, heartbrothers.org, and follow the link for the HeartBrothers House on there. Or you could just go to heartbrothers.org for any and all additional support you need, be it financial assistance, be it wanting to speak with someone, peer counseling. That's what we're there for. So as you please put your devices on mute. Please use the chat function for any comments. Raise your hand or ask a question, or enter the question in the question section. And thank you for attending. And our next patient support group, please join us on May 10th, 2022. With that, I'm going to turn it over to, I'm going to stop sharing my screen. And I'm going to turn it over to Dr. Siegel, and he can take it from there. And go from there. So Dr. Siegel, the floor is yours. Thank you.
All right. Thank you so much. Yeah, pleasure to be here. Certainly it's a small group. I'll chat, just a little bit about what I do and how I and my colleagues have worked with the heart failure patients at Tufts Medical Center for a bit, and we certainly can open it up. But obviously, as a small group, as questions come up along the way, please let me know. So I am an endocrinologist, and my focus is more in the area of diabetes, obesity, lipid, metabolic disease. I've I initially did training in internal medicine back in the early 90s, and then there's a 3-year fellowship in endocrinology, which I did at Tufts Medical Center. And I've been on the staff at Tufts Medical Center and Tufts School of Medicine since 1997 in both the Division of Endocrinology as well as our Bariatric Center, which is the Weight and Wellness Center, where actually a number of patients have been referred in terms of trying to get weight down prior to different procedures, especially heart transplants. So I guess I like to start off by emphasizing that really this is teamwork. I certainly can't do this alone. You can't do it alone. And so diabetes really has to be a team approach. And so if we think of the diabetes team, I think of the patients that we serve, myself, but also important parts to the team, diabetes educators. And we have a couple in our division focusing actually right now more on inpatient. There's a diabetes educator in the primary care clinic as well. Dietitians, definitely a very important part of our team. I try to do some of my own counseling in terms of nutrition, but cannot take the place of the dietitians. Increasingly, we've had PharmDs, so doctors of pharmacy. We have an excellent one in our division, John Aurora. Lucy, I know at Tufts Medical Center, has been a PharmD, has been a big help in terms of getting medications approved and doing teaching for that. And then, of course, we've got the consultants in cardiology, of course, ophthalmology, kidney disease, podiatry, vascular and wound specialists, social workers, and then the bariatric team. So really a big team overall. So taking a step back, just sort of thinking about what is diabetes overall, and diabetes is not one particular disease; it's multiple. And as with just anything in medicine, we could think of genetics and environment, and diabetes is often separated out type 1, which is has been called in the past the juvenile onset diabetes, but really it's immune diabetes. And it can occur really at any stage of life. The majority of people have what's known as type 2 diabetes, and that is probably multiple different genes that it's very, very familial, more familial than the immune type of diabetes. So it goes across generations. And then there are less common causes. One particular type of diabetes, which probably in a way could be related to type 2, is post-transplant diabetes. And we definitely see that early on after transplant, and then sometimes later on, and can get back to some of the triggers for that as well. But if we think about, again, genetics and environment, someone is predisposed genetically, and then the environment comes on. For type 2 diabetes, a big aspect of the environmental trigger really is related to weight and weight gain. There are certainly numerous others, including some of the various medications, exposures, and other factors that can contribute to the body not responding to insulin. And really, for diabetes, ultimately, the final common pathway is the blood sugar ends up being higher than normal. A normal blood sugar range in the American units is in milligrams per deciliter. It's generally 70 to 140 milligrams per deciliter. So different definitions as to at what point we call diabetes, but if the fasting blood sugar is repeatedly over 126 milligrams per deciliter, that can go along with the diagnosis of diabetes. If after meals, the blood sugar is going over 200 milligrams per deciliter continuously, that goes along. And then you may be familiar with the A1C test. A1C, which relates to sugar getting attached to blood cells, represents average sugar over a few months. And that's cut off normally that number's in the 5s. Cutoff usually we say is 6.5 and over for diabetes. Realize that test, if you've been transfused, if you've been bleeding, that A1C may not be accurate. So we're often using other ways of looking at the sugars in many people who may have issues related to blood. So if we think about goals with diabetes, I think about blood sugar goals, I think about weight goals, and I think about avoiding complications over a long period of time. And when I see someone as a new patient, both as an inpatient consultation, as a couple months out of the year, I'm on our inpatient service, or in our outpatient clinic, I certainly like to make sure that people are educated, and I like to discuss goals. For blood sugar goals, those really everything needs to be individualized, but most of the time we're aiming for maybe not perfectly normal, but for the sugar before meals, 90 to 130. After meals, generally under 160 to 180 milligrams per deciliter, if we're able to. And then the other thing related to blood sugar, depending on what medications people may be on, we want to avoid low blood sugar. So really trying to avoid the extremes of both highs and lows. I do include weight as a big part of the goals, because many of the medications that people are on for diabetes, as well as medications related to mood, and of course prednisone, some of the glucocorticoids, can lead to weight gain. So we're always trying to limit the impact on weight from our medications for diabetes. And insulin definitely can put on weight, though it certainly can be essential. So those are the gist of the goals: blood sugar goals, weight goals, avoiding complication, and then other individualized goals. Sometimes tobacco cessation is part of my list of goals, and often I will ask people what their particular goals are, as I would want to work with them towards that. So once I've done full history and examination, we can talk a little bit really about what the plan includes. And I like to divide up our plan into a monitoring part, a non-medication part to the plan, and then really thinking about the role of medications. So for monitoring, this has really evolved over years. Back in the 50s and 60s, people used to check their blood sugar by checking their urine in different ways and holding it, actually warming up the urine. We evolved to, over the last several decades, using glucometers, and I don't think glucometers are going away anytime soon. We can, in our clinic, which is a very techie clinic, we try to download glucometers as well as other devices that people may have to look at patterns. The newest way of monitoring blood sugars is a continuous glucose monitor, and many people have seen probably ads for some of these on TV or in magazines for the Freestyle Libre, which needs to be scanned and can go to an app, and the Dexcom. There are a couple others as well, but these are the two major continuous monitors that are available. And these are very, very valuable for giving us, even if people are checking 2 or 3 sugars a day, often you can't get a full picture. These continuous monitors are giving sugars every few minutes, and especially when these can be used together with a food log, an activity log, really context to tell us about blood sugars. It allows feedback for you, feedback for me and my team for making adjustments, to the rest of the plan. So comprehensive monitoring, blood sugar, weight, food, activity, trying to integrate that all together into journals for discussion. So that's the monitoring part. The next part really is thinking about the non-pharmacologic, and to really, I think of this as really the pedestal of treatment for all diabetes. Certainly people who do not make insulin at all, people with or immune diabetes absolutely need insulin. But for many people with type 2 diabetes, where there is often some insulin secretion along with insulin resistance, many people may be able to control their sugars with just a lifestyle plan. So there, I bring back again the role of our excellent dietitians. And I think if we think about just the different types of diet plans out there, certainly food is all over. There are lots of people have their own opinions on diets. The couple things I often put in a nutshell for when I'm trying to discuss weight, diabetes, lipid control, I discuss that I'm aiming for as much of a plant-based type of diet and unprocessed diet as people are able to do. And that's really going to be a big spreads. I'm not looking to make people into a vegetarian or vegan, but really even just making swaps out towards more plant-based unprocessed eating can have significant effects in terms of helping sugars, helping weight, helping many of these other outcomes that we're trying to go through. So really, dietary changes is essential. Activity certainly is also essential. I know for many of the patients who have advanced heart failure, heart transplant patients, that's going to be a problem in terms of really trying to be as active. So we still want to try to come up with as much of an exercise prescription as possible. I like to think of it as a prescription. And as I work with our heart failure group, actually just last week, as I did a consultation on someone who came to my weight clinic, I was discussing with our heart failure specialist, this is a patient who's eligible for cardiac rehab based on the fact that she had heart failure with reduced ejection fraction. And so, I am a big fan of cardiac rehab where it's available. I'm told that with the pandemic, and really it's a number of the programs have closed down or been reduced, but where available, I think cardiac rehab is extremely valuable because of the supervision, and in addition to the activity that goes on, certainly counseling in terms of diet and other aspects of lifestyles. So really we want to think about aerobic activity as best as we're able to, strengthening as possible. And we know that patients with heart failure can definitely lose muscle. And so we want to hold on to as much muscle as we're able to. So activity prescriptions certainly need to be adjusted based on who the patient is. But it again can have significant impact to helping blood sugar down, at least hopefully reducing weight gain, maintaining weight. All right. So the last thing as part of the plan really is medication. And medications, we have older medications, we have newer medications, both oral and injectable. And we can certainly discuss some of these more in depth. But older medications go back to the 60s and 70s. And these are medications that push insulin out of the pancreas, like glipizide or glimepiride. Metformin has been around since the 1990s or so, and metformin is good for blood sugar. It's also good for weight. One limit with metformin is if kidney functions below a certain level, the dose needs to be cut down or sometimes stopped. Some of the newer medications, as you may be aware, have actually been shown to be beneficial in patients who have heart failure. And so these The category, one of the key categories is known as Sglt2 inhibitors. So these are medications like Jardiance, Farxiga, probably are the most common of the two that are being used. And they can have effects in terms of blood sugar, but independent of blood sugar, they've been shown to reduce the risk for hospitalization from heart failure. So patients are now, actually, with the latest guidelines that have come out for heart failure just about a week ago, they are an essential part of the treatment plan. As sort of 4 different categories of medications. These SGLT2 inhibitors are one of those key categories that are now being considered. So blood sugar, as well as really, at this point for the heart and even for the kidney. Glp1 agonist is another relatively newer class, now about 15 years old. It's been shown to reduce the risk for heart disease, such as heart attacks and probably strokes. Not so much necessarily specifically in terms of heart failure, but very helpful for helping to get weight down as well. And most of those are injectable. There is one medication that's oral, and these are medications such as Ozempic, and Trulicity, and Rybelsus. So we've been moving more towards some of these newer medications because of their beneficial effect on both blood sugar, weight, and certainly the heart and kidney. Potential downsides, they're not generics, so cost certainly can be up, and we need to obviously to consider that overall. Insulin certainly continues to be the heart and soul, a main treatment for many of the patients, especially in the hospital. And when people are in the hospital, there are often relative contraindications to many of the other medications. So insulin actually just turned 100 years old from its discovery in Canada, 1921, 1922, and it's gone through evolutions. Thinking about insulin, really, there are long-acting forms of insulin that can last up to 24 hours, even up to 42 hours. These are medications, names you're probably familiar with: Lantus and Tresiba and Toujeo, and others that are similar to that. So they're relatively flat background insulins. So insulins that are needed even if people are not eating at all, to help get blood sugar down. Shorter acting insulins are used when people are eating, and I call these bolus or mealtime insulins. The most common ones would be Lispro and Aspart, Humalog, Novolog, and those tend to be matched up generally with meals. So longer acting, shorter acting. Insulin can be given the traditional way by just vial and syringe. Most of our patients who take multiple injections use pens. And then I have a number of patients, I can think of a few patients who either leading up to transplant or after transplant are on insulin pumps. And that's certainly something that we could discuss if you're interested. And so we get to trying to create more of the artificial pancreas. Pumps, along with the continuous glucose monitors, are really starting to work together, so that they feed back such that the pump reacts to the blood sugar in terms of making some adjustments. And there are 3 major systems available for that. All right, so the last just couple things I think to bring up is really thinking about just the effects of other issues on blood sugar. So heart failure itself, heart failure can make a person really fairly insulin resistant. And so in heart failure, it's been shown stress hormones go up. As the stress hormones go up, blood sugar can go up, and it can really make blood sugar, even if people are not eating differently, more difficult to control. So heart failure is definitely an insulin resistant state. Kidney disease, we know many patients with heart failure can get coexisting kidney disease. When kidney function gets very low, insulin needs often go down because insulin is actually processed by the kidney. So if people are on insulin, we need to be aware for low blood sugar. So often really a balancing act. Thinking about medications, I think the key medications that impact in terms of blood sugar are, as we think about transplant, early on after transplant, there are intravenous glucocorticoids. So that would be like Ciamedrol, oral glucocorticoids like prednisone, that really can play havoc with blood sugars. And so our team gets called in. Often we're following these patients, before transplant, and then they have their surgery, and we get consulted right afterwards. Patients go on to drips of insulin in the intensive care unit, and as they're trying to come off of those drips, we get asked to help out with orders to move from the intravenous to the subcutaneous forms of insulin. We're needing very, very high doses, and the good thing about insulin is some people need as little as 10 units a day. Other people need as much as 200 or more units per day. And so we need to adapt based on the stress factors that people are on, the medications that people are on, and their overall situation. So really day to day, we're evaluating that with the inpatient teams to make adjustments. So that's early on after transplant, but as you get later on after transplant, tacrolimus and cyclosporin can have other effects in terms of how the body makes insulin and how it responds to insulin. And so later onset post-transplant diabetes is often related to these long-term immunosuppressants. And so some people, have been on insulin, they were able to come off as the prednisone and steroids come down, and then we end up seeing them again a couple years later for that late onset. Last thing I guess I'll mention before we break for questions is the fact that this is more than just blood sugar. Again, I emphasize we're thinking about blood pressure. We're thinking about the weight. We're thinking about the lipid control, and certainly cholesterol can go way up with certain types of immunosuppressants, like sirolimus, especially if that's on top of someone who has genetic issues. So we're really trying to look at all these factors together, which is where certainly I need some of my colleagues, like the kidney doctors, to help out with this. So I think I will leave it at that with my introduction, and I'm happy to take any questions or comments.
So, Doctor, thank you so much. So I had a question. Can diabetes itself lead to heart failure?
So it does seem that over a period of time, diabetes is a risk factor for heart failure. Whether that separates out type 1, type 2. So I think there probably are coexisting factors. We know that just high sugars over time are bad for blood vessels, and that's separate from high blood pressure and cholesterol. But I think with all the both cholesterol, blood pressure, diabetes, the heart can certainly remodel over time. It's thought that while some of this may be related to the sugar, a lot of it actually may be related to the weight as well. So sort of putting type 2 diabetes with excess weight, we know that there can be an obesity-related cardiomyopathy that's been described. So probably a combination of factors, but it does seem that diabetes tracks with increased risk for heart failure.
Pat, you're on mute.
Okay, so yeah, please unmute. Everyone can probably unmute.
Hi, it's Pat Sullivan here.
Hi.
Nice to see you again. I think we saw each other once.
Yeah.
How many patients in general get off of like glipizide post-transplant? Once I got off the prednisone, which I think was 9 months post-transplant, all of a sudden I weaned off of the glipizide within 5 months. Is that fairly common or not?
Yeah, no, I think especially for people who did not necessarily have diabetes beforehand. So I think
Right.
Many of the people before transplants, while there are a lot of people with diabetes, a lot of people were sort of right on the edge per se. And so if you have pretty good function in your pancreas, once the stress and really insulin resistance comes down with prednisone coming down, the pancreas can wake up.
Yeah.
Part of it's related to age. As everyone gets older, you probably lose some ability to make that insulin. Yeah, so I see a number of people who are able to come down off of everything, and just monitor blood sugars. And blood sugars may not be perfectly normal, but again, as we're obviously, as you can tell me better than I know. Med lists are very, very long, so I'm always an advocate to see how low can we go in terms of cutting back medications that may not be essential. So if I think the most of the sugars can be tracked and stay in that 90 to 180, maybe occasionally going up to 200, but really 90 to 180 range, just with best diet and activity, then people can come off of glipizide or some of the other medications.
One other question. I continually get blood tests, a whole panel of blood tests. My A1C is always in the fives, low fives. So should that be an indicator that I'm doing well, or is that?
It should be, as we mentioned, A1C sometimes is not perfect, depending on if people have anemia or something else affecting blood cells. But assuming not, I mean, this is where, again, we try to sometimes correlate. If someone's checking finger sticks and they're all in the 200s and their A1C is 5%, we know something's off with that.
Yeah.
But I think if A1C is 5% and you're either not checking sugars or on random blood draws, the sugars tend to be low 100s, then I think the A1C certainly can be tracked over time, and if that drifts up, that could be a sign to perhaps do some other sort of form of monitoring.
Well, they keep saying everything looks good, including that area. So I guess they would refer me back to you or to Dr. Seglia or someone else, right?
Yeah, I mean, I think, I think certainly the team is keeping an eye on everything very, very closely. So I think they're often looking at A1C. I mean, I think it's usually a combination of A1C and at least casual blood sugar. When a blood sugar is drawn, I mean, sometimes it's fasting, sometimes it's not, and we need to sort of think about when the timing of that when the blood is drawn.
Okay, great.
Darlene, go ahead.
Hi, I work with the Brigham's. I'm a heart transplant, and Dr. Cho is my endocrinologist. He's mostly looking at my bone densities and such. I've had A1C checked because I have constantly nonstop dry lips, always thirsty, and I'm tired. Okay. And those are the three indicators of diabetes, I guess. But it always is good. They say the A1C is always fine. So I don't know what it is, but I'm on prednisone continuous prednisone, 5 mg, probably for life. Why do you say vegetarian diet is better, more plant-based, as opposed? Is the meat because of cholesterol? Is that why you don't like the meat?
So you need protein, and so I think protein obviously can come from all different sources. Much of what I guess I'm referring to is a lot of these are some of the long-term studies that have looked at Mediterranean diet, DASH diet, and just in terms of many of them have shown reduced risk over time for people either developing diabetes, developing heart disease. So looking at just patient-based outcomes over time, it tends to track. That doesn't mean, so I certainly, everyone needs protein, and we want to, I think you can certainly get protein from animal sources, plant sources, dairy sources. I
eat cheese.
What's that?
I eat cheese.
Yeah, so certainly, for cheese is going to give you calcium. It's going to give you protein. I think everyone really needs to individualize their diet. overall. And a fully vegetarian diet is not going to be appropriate for many people based on, for one, food preferences. And others may not be able to get actually adequate protein in. It's tougher in terms of the plant protein. I mean, it's soy, it's legumes, it's nuts and seeds. Some people can tolerate these well, others not.
Well, I have diverticulitis, reoccurring. So, I got a lot of issues going on, but yeah, I like meat. But, like I went grocery shopping today, and ground turkey is more than filet mignon right now. So
it's tricky. Definitely the cost of everything has gone up, and I think a lot of the animal protein sometimes I think it seems to have gone up more so. So that's why I say I talk to people, go as much plant-based as you're able and willing to go. And really, a lot of it's really about the processing. So even amongst meats, processed meats, bacon, sausage, hot dogs, deli meats have a higher risk in a number of studies for cancers. They tend to be saltier. So I was thinking about, certainly about the sodium aspect of things as well. A lot of these nutritional research is tough. A lot of it's been done through the Harvard School of Public Health across town, where they look at just what people eat and different outcomes over time. And red meat, processed meats tend to track with weight gain. They tend to track with a number of adverse outcomes.
I like a good.
Yeah.
But I guess we don't eat it a lot.
No, I think everyone needs to individualize, and that's where sitting down with your own doctor, your own dietitian, to really say, I mean, maybe for people who are eating meat at 20 meals a week, and they go to just a handful of meatless meals, there certainly can be benefit to thinking about that.
Thank you.
Lee, did you have a question?
No, I'm just 100% in agreement with Dr. Siegel about the plant-based diet and I totally get, Darlene, it's not easy, but just baby steps towards it is what we're trying to do in our house. Yeah. Dr. Siegel, I also wanted to let you know, I'm going to be writing up a blog about this today. So I know it's a small group, but we'll be sending it out to, our thousands of followers. It'll be on social and on our website and in an e-blast. So people will hear what you have to say, which is really important.
All right, wonderful. Certainly happy to comment to anyone in your group as need be.
So,
great, thank you.
So there's been some discussion about prednisone. So some of us are on long-term 5 milligram maintenance dose of prednisone. I guess my question is, with the risk of diabetes, how hard should I try to convince my cardiologist to take me off of prednisone?
At 5 milligrams a day, there's probably still some risk. 5 milligrams is about the equivalent of what the body itself makes. So remember, the adrenal gland that's on top of the kidney makes cortisol. And when you're on very high doses of prednisone, it actually feeds back and temporarily shuts down your body's ability to make that cortisol. As the prednisone dose comes down, ultimately, hopefully you come to a steady state. I mean, there's still probably some risk, but I think in terms of weighing out the risk for rejection, certainly if prednisone is key as part of your particular cocktail in terms of avoiding rejection. Some people are able to come off of it, others can't. Obviously, we need to be thinking about the bone issue for topic for another day, perhaps with Dr. Seglia. But so it's trading off, and certainly I remind anyone who's on chronic prednisone should have a medical alert bracelet or chain indicating that they are adrenally insufficient. And it gets away from the diabetes aspect a bit, but hopefully it's been discussed about stress dosing. So separately from the heart transplant, I mean, if you're sick, I tell people, often you're doubling up for a couple days because you're doing what your body would normally do and then coming back down. And if you were to collapse, someone needs to know that you're on chronic prednisone. Certainly, if your medical alerts indicate you're a heart transplant patient, that might be assumed, but adrenal insufficiency should be on there so that in the field you could get intravenous or intramuscular form of steroid to help support your blood pressure. So, I think if your transplant team feels that the fibroprednisone is keeping you out of trouble, I would stay with that. I mean, if it could have come down to 2.5 and still keep you out of trouble, I suppose that's something you could query. Okay.
Thank you.
Doctor, can I ask you a quick question? It's actually a two-point question. One is, what % of folks with heart failure develop diabetes? Do you have a sense, the ballpark? And then the other side is, what % of folks with diabetes will develop heart failure?
Yeah, so I probably should have looked up some of these numbers ahead of time. Of the people with heart failure, I would guess it's somewhere in the range of, certainly if you bring in at risk for the pre-diabetes category, the number goes up probably, well above 50%. I would think somewhere, maybe 40 to 50% will actually have diabetes. And if, for dysglycemia, some sort of abnormal blood sugar, it probably gets, 70, 75, 80% is my thought. In terms of diabetes and number of people who get heart failure, that number is probably much lower per se. I mean, over time it goes up, but if you look at the numbers of people with diabetes, in the U.S. it's I think 35 million. I would think that the number is probably down, could be 5 to 10%, or maybe less than that. I don't know those numbers off the top of my head though.
Yeah.
Any other questions, discussions?
What role does diabetes play in exercise? You really emphasize exercise. What does that do?
So we know that exercise, even without weight loss, can make you more insulin sensitive. So depending on the exercise, with aerobic exercise, we see that blood sugars definitely come down. And this is times, for people who have the continuous glucose monitors, they can get that immediate feedback, seeing that they're high after a meal and they take a walk and blood sugar comes down. That's good feedback. Strengthening is important in the short term. Blood sugar actually can go up if there's significant weight training. In the long term, though, because muscle mass helps to metabolize blood sugar, it's really gonna help out. So we know that for people who don't have diabetes, if you increase your activity, it can reduce your risk for getting diabetes. There's an old study looking at people in that pre-diabetes category, where their fasting sugar was a little bit high and their after meal sugar was a little bit high, and they randomized them to a lifestyle plan versus metformin versus just general counseling. And over the first few years, the people who lost about 7% of their weight and were active for 150 minutes per week did the best in terms of not converting from pre-diabetes to diabetes. So helpful in terms of hopefully reducing the risk for getting diabetes. Once diabetes is there, definitely is an important part of the non-pharmacologic treatment. And a lot of this, again, is for people who are on meds, the whole aim is to try to reduce the need for medication. People on insulin, we try to come down on the insulin doses as much as we can, or perhaps convert from insulin to something that's not going to put weight on and not cause hypoglycemia, low blood sugar.
Sounds eating good is just for all around health. Exercising, it's like basic for every type of ailment.
It really is, and people are trying hard to sort of capture exercise in a pill to understand really what it does at the muscle level. And we're trying to, we do get a sense, we know that when muscles contract, there are different proteins on the cells that take up glucose, that more of them are coming to that cell surface to take the glucose up. But you're right, certainly for both mind and body, we know the significant benefits of exercise, which is where I'm a huge fan of cardiac rehab, where it's been used. Have of people who are here, have you been in cardiac rehab programs?
Yes.
I have.
Yeah.
For me, it's a vicious cycle. It goes feeling good, getting in shape, diverticulitis, going downhill, sleeping, resting, nothing. And then it takes forever to get back. And then I get diverticulitis again. So I've been in touch with Brigham's, and I may end up with the gut surgery. It might end up being the best thing for me.
Yeah, no, that's certainly a difficult thing. I guess understanding. I mean, what's the trigger for your diverticulitis? I mean, it used to be thought that popcorn and nuts actually were triggers, and it seems actually probably not. Definitely a higher fiber diet for which, I mean, popcorn's a whole grain, and nuts have fiber, so that definitely as high fiber diet tends to reduce the risk. There maybe there's something else structurally there that is contributing per se. But I'm glad people have been in the cardiac rehab programs. What programs have you been in?
I've used the one in York with York Hospital. I live in York, Maine, and they have a very nice program.
Good.
I was at UMass.
Nice.
And so I lived in Western Mass, so I was at Bay State. They had a cardiac rehab there.
Good. Yeah, that's great. Yeah, Tufts has not had one, and I think depending on people where they are, we've referred out. I know Boston Medical Center has had one. South Shore Hospital has had one. But yeah, it's unfortunately I was emailing with one of our coordinators in the heart failure program, and it's a shame that heart failure with preserved ejection fraction is not a qualification for cardiac rehab under the Medicare rules. That's sad. So many people can really benefit from it.
Wow, that's crazy.
That is crazy.
A question. We're seeing so many people on CBD and or THC.
Yeah.
What effect does that have, or is there any correlation with diabetes?
I'm not aware of any specific correlation that I've seen with that.
Okay.
So I know it could have benefits, but I'm not aware that it necessarily raises blood sugar or will increase the risk for low blood sugar. So
Okay. All righty.
So I had a question, not taking advantage of your time, but since we got you. So, diabetes has a lot of side effects. For example, neuropathy, effects on your vision and stuff.
yeah.
People who are having the continuous glucose monitoring, which it's a feedback to the insulin pump based on your body's sugar level, does that actually work like a real pancreas and reduce your risks of all these side effects?
So it seems the bottom line is, for some of the, at least for some of these microvascular disease, so that would be the retinopathy, neuropathy, kidney disease, anything that can really get blood sugars down into range and really also avoiding the low can do it. So the smart systems that we have right now, where insulin pumps and continuous monitors working together, it's if we can get sugars down and also reduce the variability, it seems that that's good for blood vessels. But it can be done, without a pump as well. Certainly we have patients on continuous glucose monitors who are on insulin injections or oral medications. It seems if we can safely get sugars, A1C down towards 7%, if A1C is accurate, that can reduce the risk. And whether that also reduces the risk in terms of heart failure, I think not as clear. I don't think that's been looked at as well, but at least for some of the microvascular diseases.
Thank you.
Doctor, quick question. You mentioned that, put a lot of emphasis on weight as an important factor. I know that I think BMI has kind of been, is not as much in favor anymore. I don't think, and obviously it's a discussion you have with your doctor, but is there an easy suggestion or sort of equation that you have for ideal weight?
So BMI is still going to be pretty good in most people for just correlation with fat. There are certain populations, so South Asians, East Asians, where there is a significant amount of deep belly fat, visceral fat, such that the absolute weight in BMI can look relatively normal, but their waist circumference. So, waist circumference probably is, a good correlate. Some people look at, waist to height ratio. I mean, there are different types of things, but, a simple sort of thing is, if you look at waist circumference for, in the majority of people, again, there is probably some differences in terms of ethnicity in inches, under for women under 35 inches, definitely lower risk in men, under 40 inches, but probably even going down further. So sometimes tough to measure. Obviously, it depends on where you place it, but really it should be at the top of the iliac crest. That's the top of the hips is the best place in terms of measuring that. And that belly fat, I mean, it correlates with risk for fat in the liver, risk for high triglycerides, and sort of coming back to the obesity-related cardiomyopathy, that visceral fat, it's releasing, fatty acids. So, and it's thought that fatty acid from the deep visceral fat is depositing in the heart, as well as other organs per se. So we really do want to reduce that belly fat. And what reduces belly fat? We know, again, activity, even without weight coming down, can reduce weight, belly fat. The overall dietary sorts of things that we've talked about do tend to correlate with less in the way of the visceral fat. There definitely are genetics that go along with it one way or the other. But a number of the lifestyle sorts of things tend to track with the reducing the visceral fat. So I think if we're going to eliminate BMI, I mean, I would probably look at waist circumference, and people have looked at other types of ratios as well. And there are sensitive, in our weight and wellness center, we do have a body, a BIA that looks at percentage of body fat and muscle, which is maybe not 100% accurate, but you can take a look at that as well. In research, they do different scans that can look at body composition and look at the amount of visceral fat, different types of CAT scans. We don't usually do that. So I think the easiest way, waist circumference.
Gotcha. Excellent. Thank you.
All right. So my wife is on glipizide, metformin, and Ozempic, and she's diabetic too. What should she do?
So definitely three medicines that work in different ways. So metformin, as we said, and glipizide have been around quite a while. Metformin, we were still actually learning how metformin works. We know it tends to reduce how the liver makes sugar. It may actually have effects in the gut to change perhaps some of the bacteria in the gut and help to get sugar down by stimulating some of the hormones there.
Yeah.
But metformin and Ozempic are both good for blood sugar and for weight. Okay.
Yeah.
And those by themselves cannot cause low blood sugar. Glipizide certainly can. So I guess, what I would want to know is, are blood sugars doing well for your wife? Are they trending low such that the glipizide might be cut out? Or if her weight were to come down, the first thing that I would try to do would be actually get rid of that glipizide, because that would eliminate her risk for hypoglycemia, per se, and then she would be on the most weight-friendly regimen, which would be conducive with a lifestyle plan.
Yeah. All right.
All right, so we've taken up close to an hour of your time, so thank you so much. There are no
Thank you.
other questions. Really, really appreciate this. And as Lee said, I apologize why we had such a low attendance number, but we put the video both
That's
on our
fine.
website and Lee writes up a really nice blog and we send it out to people. So this is really vital information for people's health. So we're going to get it out to a lot of people. So thank
Excellent.
you.
Well, definitely happy to do it. As I tell our patients, we're an extension of the transplant team. We're an extension of the heart failure team. And we need, we need each other. Patients need their physicians, and I think really everyone else on the team. So team approach, and certainly if other questions come up, feel free, let me know. And certainly Hamid has my email. I'm happy to take any emails if questions come up.
Thank you.
Great. Thank you, doctor.
All right. Have a good night and
Doctor.
have a good
You too.
Thank you.
weekend.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Are we leaving?
Yeah, we're leaving.
Good
Thank
night.
you, Charlie. Thanks for coming. Really appreciate
You're
it.
welcome.
Yeah.
I was sleeping and I was like, oh no. I
thank-
always do that. Bye-bye.
All right. Bye.
Anyone want? Hey, Hamid,
Hey, Pat.
how you doing?
I'm doing good. I'm doing good.
How's it feel to be home?
It's great to be home.
I'll bet. Well, you were gone a month, 3 weeks.
3 weeks. I'm going again for 1 week, but I'll be back.
When are you leaving?
Leaving Sunday, and I'll be back the following.
Easter Sunday?
What can I say? No, I'll
Yeah.
be. Yeah, I'll be leaving Easter Sunday. But
You're back in a week.
I'll be back in a week.
That's a shit pile of driving.
It is.
Yeah.
And so
Any way to fly? Wouldn't they pay for you?
the problem is, by the time I go to an airport here, which is an hour, you got to get there an hour in advance. So that's 2 hours. And then from where I work to the Pittsburgh airport's another hour and a half. And then so you're about like 4 or 5 hours in transit. And that's if you get a direct flight. If you don't get a direct flight, forget it.
Don't Manchester to Pittsburgh?
Yeah.
No,
I don't know. I don't know if there is or not.
I think they do.
But
That's just,
I like taking the car because I can take stuff with me, particularly I take a cooler and food and stuff. So
yeah,
so it's a little easier.
okay.
All right.
Well, we
I'm
obviously saw the Larry issue come up here.
yeah.
today.
So we need to. And I was going to say so. Really,
We got to figure it out. Mike's got to jump in.
I was going to say exactly since Mike is the keeper of the
Team.
relationship, the key. And so I'm going to Tufts tomorrow morning.
Yep.
So I'll be there. Today I was at Concord for a New England Donor Services event.
Yeah.
I briefly met the CEO for NEDS was there.
Oh, really?
Yes, I briefly chatted with her and I said, hey, she said, I said, we do a lot together. We'd like to do more, like to sit down and talk to you guys. And she said, yeah, anytime.
Good.
So she's a lady, Alexandra, Alex.
Yep. Yep. She's recently been in the press and she's been in front of Congress. Yep. She was one of the ones that did a bad couple of emails. Bad.
Oh,
I think she's retiring, unless this is the new person that you
I don't
saw.
know.
A lot of the OPOs,
Yeah.
their CEOs are retiring because of exposure. The Congress is taking a very, very close look at how much money they get and what kind of overheads they're doing and all kinds of stuff. But
Really? I mean,
Yeah.
they get their money from the federal government, right?
yeah, they get a ton. And CMS as well.
Yeah, and then they plus they do fundraising. I know, like
Yeah, but most of their money does not come from fundraising. A very little part, very little comes from fundraising, actually, if you look at their numbers. It's mostly from, reimbursements for their services.
So who reimburses them? Insurance companies?
No, insurance companies and CMS, Medicare, Medicaid.
Oh, okay.
Yep. That's their biggest numbers.
Wow.
And I think there's this federal fund that's just dedicated to this. I know Congress is right on top of it right now. It's been very quiet, very quiet. But there was an article in the Times and the Washington Post about it not too long ago. And Ned's person was specifically called out.
What did she do?
She said that something to the in fact that people should have lived a more healthy lifestyle, which it was regards to a transplant of some sort. And it was like people went bullshit. And somehow Congress got a hold of the emails. It was very embarrassing. But yeah, I just followed it through. I forget who told me to follow it. It was, I think it might have been Hollywood, Donate Life Hollywood person that told me about it originally. Or Joy might have said something, or Transmedics might have said something. Someone directed me to the article and sent it to me. I thought I sent it to you. I know I did, but it's old. It's like 3 months, 4 months ago.
Maybe.
Yeah. But now we want to talk more to them.
Yeah.
We definitely want to talk more to them. She was at Ned's. She was from Ned's, not Donate Life. She was at Ned's.
I mean, she was from basically she was introduced as the CEO of
Ned's.
Ned's, right.
All right. Two different organizations, yeah. Closely tied, obviously. They've had a monopoly for forever, ever, which I can understand.
Yeah, I mean,
why it should be a monopoly in a market.
Yeah, I don't know if I'd want a commercial competitive type thing on that.
No, I don't think you do, but they should be held accountable though.
Oh, absolutely. Pat, everybody should be held accountable.
Yes.
Everybody.
Right. Yep. So anyway, I thought there were some good questions tonight. He's a very nice guy. I did meet with him.
Okay, yeah, he's a great guy. And again, it is good to have access to different specialists.
Sure. As many as we can get.
As many as we can get,
Yep.
To just broaden our.
We got to bring the UMass people in.
Yeah.
I mean, Mass General people into this.
Well, so, what we need either Glenn or somebody.
Yep, Glenn or Ed.
Or Ed take a more proactive role in bringing them in.
Yeah, they just got to be asked. They'll do it.
Okay.
They'll do it. They just got to be asked.
Okay.
All right. Other than that, you're good.
I'm good. I'm very good.
I hope this shot helps tomorrow.
Yeah.
God.
Still having.
Oh. It went to I could function.
Yeah.
Back to terrible.
Oh wow.
Yep.
Surgery an option or no?
They don't want to do surgery at all. They said no, because it involves screws, plates. And they're like, you don't want to open up to infection that close to your spine.
Right.
If we could. So usually a lot of times it takes 2 to 3 of these shots to.
How many have you had?
One.
Oh,
They got
okay.
1 month apart. They can't be like 2 weeks apart.
Okay, well, so hopefully next one
Yeah.
should work.
Yep. And a lot of it has to do with sleeping, how you sleep. And I have this one pillow that I put between my legs, and I had a different pillow up in Maine, and it got really bad up there this week. And so I got to bring that pillow with me.
Yeah, look at the mattress you have down here versus.
Well, I know we got to get a new mattress as well. So That's next on the list. So,
I hear you.
yeah. All right.
All right. Take
Uh,
care.
That's good to see you.
Good to be back.
Yeah, good.
Good
Yeah.
to be back.
All right.
All right.
We'll
See
talk
you.
tomorrow. I'll
All
talk
right.
to you.
Okay.
Bye-bye.